Yeah, about a minute left.
Do we ask our questions out loud?
You don't have to. I mean, they're going on the Menti code anyway. You can say that this is a question on the Menti on the Mentimeter if you'd like to answer it, and we'll give you the answers at the end, something like that.
Okay.
Good morning, good afternoon, good evening. This is the worldwide webinar, WSPOS Season 2, webinar number 6. I have not looked forward to a webinar like this for a long time. This is pediatric uveitis. I can't begin to tell you what a wonderful panel of speakers we have today. They are just amazing. You're going to learn so much. Thank you so much for being with us today. In a time of destruction, Maxine Hong Kingston said, create something. And that is what WSPOS has tried to do. With your help, we've created one of the largest webinar series ever to be produced for pediatric ophthalmology and strabismus. Thank you. Thank you so much for making this happen. So, all of this work, there's so many people behind the scenes. There's our scientific bureau. There's our ethics bureau. There's our connectivity bureau, 2 members at the moment who have just joined and not on there. And we have our whole backroom staff, our administrators, who I'll be mentioning later. So thank you so much to everybody. So for this uveitis webinar, the Menti code is 3948568. I'm going to repeat that, 3948568. That's the Menti code. I hope you are watching and will participate in that code. Okay, I was really pleased that we were able to do this webinar, and I want to tell you something that is really close to my heart. When I was 19, at the end of my first year in medical school, I worked as a hospital porter, and I worked at the Canadian Red Cross Memorial Hospital. That was the hospital that Barbara Ansell, the woman that you're seeing on the left of your screen, worked at. And she is considered to be the godmother of pediatric rheumatology. And my job was taking these children with severe crippling JIA to the hydrotherapy pool. And the man you see at the top right is Jack Kansky. And that was the first time I met him because his MD thesis was the investigation and evaluation of the uveitis in these children. So I kind of feel that that's an important link to share with you. So it gives me great pleasure to start to introduce our panel. Dr. Nisha Acharya, there she is with her lovely family. She's the president-elect of the American Uveitis Society. She's the Elizabeth C. Proctor Distinguished Professor in the Departments of Ophthalmology, Epidemiology, and Biostatistics in the University of California, San Francisco. She's director of the Ocular Inflammatory Disease and Uveitis Service and associate director of the Proctor Foundation. I can't tell you how great it is to have you, Nisha, on this panel. Her bachelor's degree and master's were at Stanford, medical degree at UCSF, residency at Mass Eye and Ear, fellowships in cornea and external disease and uveitis at UCF's Proctor Foundation. Well, I can't tell you how excited we are to have you.
Thank you.
Dr. Sanna Leninen, an amazing woman. She's from Finland. I want you to know that her eyelashes are actually frozen in this picture on the left. I think Sanna told me it was minus 25 degrees. She's from centigrade, that is, from Finland. Her focus has been on pediatric uveitis since 2013. She finished her thesis dissertation on juvenile idiopathic arthritis-related uveitis and has been looking at other rare causes and systemic disorders associated with uveitis. And her pandemic-safe pastimes include clinical work, research, and teaching at her university hospital, and exercising at home and outdoors, and of course, eating chocolate and binge-watching cooking shows. And it always makes me very unhappy that people who eat the most chocolate are the thinnest, so apart from me. Okay, so on that note, I really want to introduce my co-moderator, Somashila Murthy, who I've known for years. She's at LV Prasad Eye Institute. Here she is with her family and her husband. She's an alum of the Nair Charitable Hospital in Bombay, specializing in ophthalmology at Bombay also, clinical fellowships at LV Prasad Eye Institute and the Doheny Eye Institute in LA. And apart from her work at LVP, she's passionate about mentoring women entrepreneurs and participating in team building activities. She's currently part of the All India Ophthalmological Society. What can I tell you? She's so well published and an absolute pleasure to have her here today. I'm going to hand it over to Somashila, but before we do that, I am getting dings from all over the world. We have listeners right now, watchers from Egypt, Lebanon, Sweden, USA, France, India, Chile, Argentina, Indonesia, Brazil, Nigeria, South Africa, truly global. Sheila, all yours. Somashila, all yours, sorry.
Thank you very much, Ken. A very warm welcome to everyone, and good morning, good evening, good day to everyone. And it's really my pleasure to be part of this webinar. And it's also my distinct pleasure to introduce none other but the grandmaster of this entire session, that is Professor Ken Nischal. So we do know that he's a division chief of the pediatric ophthalmology and strabismus, and as well as the executive vice chair in the Department of Ophthalmology at the University of Pittsburgh Medical College. He also is a medical director at the digital health of the same place, as well as being the assistant medical director and the co-executive director of WSPOS. So since he has prepared the summary, so obviously he is very modest. He has many, many other credits, and he is extensively published, as well as having multiple interests in pediatric eye disease. Especially, I know him about his interest in pediatric cornea. He has produced a lot of path-breaking research in pediatric lens surgeries, as well as glaucoma and genetics, and so have you. So the next speaker that I would like to introduce is Dr. Marie-Hélène. She's done her MD PhD and is an associate professor in ophthalmology at the UPMC Eye Center and Children's Hospital from Pittsburgh, USA. She's also completed her specialized medical studies in ophthalmology, as well as her basic medical degree. And also she's a double doctorate, so being a medical doctor, as well as a PhD in neurosciences from Paris in France. And she has done a clinical fellowship in medical retina, uveitis, and vitreoretinal surgery from the prestigious Moorfields Eye Hospital in London, and also was in UK and in Europe and teaching fellowships at the University College of London. And she's an associate professor at Paris, France earlier. So she's also a member of the Pittsburgh Ophthalmology Society, and I think we connect that she's also a member of the Intraocular Ocular Inflammation Society, as well as the co-founder and executive committee of the Women Ophthalmology, which is a group close to my heart, and a member of the editorial board of the PLOS One journal. So with that, I'd like to introduce Dr. Ginny Miraldi Utz. I knew Ginny when she visited us way back 10, 11 years ago at LV Prasad in Hyderabad, but she was such a cheerful person then, and she continues to be the same. She's currently the Associate Professor of Pediatric Ophthalmology at the Cincinnati Children's Hospital and Medical Center. Her subspecialty interests include, of course, pediatric uveitis and ophthalmic genetics. And she's also a member of the American Uveitis Society, as well as being the chairperson of the American Association for the Pediatric Ophthalmology Uveitis Committee. And I'm sure that she has multiple other laurels to her credit, but we are very eager to listen to Dr. Virginia's talk, which is going to be the first talk of the session.
So if you'd like to share, Ginny?
Yeah.
So while we're doing that, just to let you know, I have other dings coming. We have Zimbabwe, Turkey, Sri Lanka, Bangladesh, Portugal, Peru, Malaysia, France, I've already said. So take it away, Ginny. We've got a global audience.
Great. Thank you, Dr. Somashila, for that great introduction. And thanks, Dr. Nischal. It's really a pleasure to be here today. So I will be discussing the evaluation of the pediatric patient presenting with uveitis. Here's the question. We're going to present it here, and then we will give you the answer at the end of the lecture.
Ginny, could you go to presentation mode, please?
Oh. Apologies there.
No worries.
Uveitis is an important cause of vision loss in children. The differential diagnosis includes infectious, non-infectious, and masquerade syndromes. And juvenile idiopathic arthritis, which some of my colleagues will discuss more about, is the most common systemic etiology in North America and Europe. So when evaluating a uveitis patient, a comprehensive history is key. You want to get all of the records, really understand the clinical course in terms of the temporal progression. Was it subacute, acute, more of an asymptomatic chronic presentation, and have a sense of the disease course, current treatments in response to prior treatments. I also really like to know if the history of ocular hypertension, was the IOP high on presentation, or was it after the steroids were initiated? That will help shape my differential diagnosis. Review of systems is important. The family may brush through them, so it's good to point out specific aspects of the history. You have to be a detective, and so here are some worldwide famous detectives. I guess we use a slit lamp in our other modalities, and as opposed to a magnifying glass. So for the comprehensive history, past medical history is important, including the immunization status, whether or not the patient's immunocompromised, such as in HIV or bone marrow transplant, existing medical conditions. It's important to also consider medications, especially new ones, because some medications are associated with uveitis. Family history is important. And then social history is very important. And I'm going to show you on the next slide some of the things you might forget to ask about. But a child that's eating dirt, pica, you're going to worry about toxicara. Pet tarantula, who'd have thought that could cause uveitis, pet exposure, travel history, new tattoos. So everything's fair game for uveitis. This is followed by a careful, comprehensive examination with descriptive naming, identifying the pathology, whether it be granulomatous, non-granulomatous, the anatomic location of disease, anterior, intermediate, posterior panuveitis, keeping in mind that you can have secondary complications as the result of primary disease in the anterior segment, such as CME or papillitis. And then it's also important to distinguish whether you have anterior vitreous spillover versus a true intermediate uveitis by looking for snowballs, snowbanking, exudate on your posterior segment examination. In terms of anterior segment findings, paying attention to keratitis, endotheliitis, chorotic precipitates, noting the size and appearance, whether they're granulomatous versus non-granulomatous, and the distribution is also key. Are they diffuse, central, paracentral, or are they in, the traditional Arlt's triangle in the inferior cornea? In terms of the iris, looking for nodules, synechia, transillumination defects. And then, of course, we want to quantify how much inflammation that we're seeing. This is, I think it's important to also, because sometimes there's just low-grade inflammation that we're following, especially in JIA, to actually document the number of cells we're seeing per high-power field so we can compare. Conventional slit lamp exam is really needed to evaluate for uveitis. And sometimes you have to be very patient, examine family members, examine stuffed animals, whatever it takes to get the child to the slit lamp. A portable slit lamp is not ideal, but you can certainly see complications with a portable slit lamp. Here's a clinical pearl. When to suspect a viral etiology. So if you have a patient with recurrent or chronic or sometimes subacute unilateral non-alternating anterior uveitis, this should be in the back of your mind. History of ocular hypertension with each episode of uveitis, because the trabecular meshwork becomes inflamed, a trabeculitis has developed. And then the KP distribution is characteristic. Instead of in the traditional Arnold's triangle, they may be more central, above the corneal midline, and occasionally they're diffuse. Iris transillumination defects may also be present, and then it's much easier if there's a history of keratitis or keratitis present when they are there for examination. Here are some examples of HSV keratouveitis. You can get in a hypopyon, and always remember to check corneal sensation prior to anesthesia. In terms of key posterior segment findings, vitreous haze, you want to quantify that. Snowbanks, snowballs, exudative detachment, vasculitis, infectious lesions, including chorioretinal scarring. And it's really important to evaluate out to the ora serrata, and sometimes that does require an exam under anesthesia, but there can be significant pathology to take into account. We have a lot of imaging studies, and some of my colleagues will discuss more on these today, but the macular OCT, monitoring for cystoid macular edema. And I use the NFOS color map because sometimes you may not have cystoid spaces, but you may have more diffuse thickening. And so I will follow that. An optic nerve OCT for papillitis, and then Optos Whitefield fundus imaging, and finally, fluorescein angiography. While IV is the gold standard, oral fluorescein can be very helpful, especially in younger children. And so I'm going to show you a brief example here. So this is a 13-year-old girl with parsplenitis. She's 20/20 in each eye. There's no CME on OCT, and the fundus looks relatively normal. This is the right eye, and you can see that there is leakage that extends posteriorly, not involving the posterior pole or the macula. And then this area of hyperfluorescence, actually when you scleral depress her, she actually has snow banking. And so, this is the left eye in comparison, with some non-specific peripheral leakage, but nothing, not nearly as impressive as the right eye. So in summary, comprehensive history and exam leading to a differential diagnosis, and then phenotype-driven laboratory and imaging studies. And then the answer, so Keratic precipitates an Arnold triangle distribution. In viral etiologies, it's diffuse or pericentral. If it crosses the midline, have viral in the back of your mind. Hypotony on presentation, answer B. No, it's usually hypertensive on presentation. Transillumination defects of the iris, so that's characteristic of herpetic viruses. And then iris nodules, you'll see more with granulomatous, infectious and non-infectious causes. Thank you, everybody. It's really nice to be here today.
Thank you so much. That's fantastic. I'm going to ask Nisha Acharya to share her screen. While we're doing that, I'm getting told off because I didn't mention Italy, Cyprus, Georgia, Belgium, Albania, Hong Kong, Singapore, Algeria, Malaysia, Brazil, Kingdom of Saudi Arabia, and Peru. Okay. You're doing great. Are you okay? There you go.
Yes, sorry. The presentation thing just disappeared. I'm sorry. I don't know where.
No worries. So while Nisha's getting ready, so Sheila, any comments on Ginny's talk?
Yes, Ginny, a wonderful talk. I think you managed to cover a lot of ground in a very short span. And I think the clinical pearls that you gave on herpetic uveitis as well as viral is very important and probably underdiagnosed. So is there any pattern that you look at for chaetic precipitates that you can look at and think about sarcoidosis? Because we do see a fair number of children with these precipitates.
So I usually look for mutton fat KP, usually in an Arlt's distribution. Depending on how dense they are, they sometimes go above the midline, but usually the most concentrated in that Arlt distribution.
All right.
Okay.
Great. Nishal,
Can
yours.
everyone? Great,
Yep.
thank you.
You
Just
look
want to say, yeah, thank you, Dr. Nishal and Dr. Murthy. This is a wonderful forum, and I'm really pleased to be here. So thank you very much for the invitation. So I am going to spend the next number of minutes, eight minutes or so, talking to you about treatment of juvenile idiopathic arthritis associated uveitis. It's a major cause of uveitis that we see in the pediatric population. Some of the medications that I will speak about are considered off-label. They're not approved for the use in uveitis, but they are used. All right, so just to start, a bit about JIA, juvenile idiopathic arthritis. It's actually a number of conditions. There are 7 subtypes that have been classified by the International League of Associations for Rheumatology. And I won't go into all of these, but I want to just mention these because it's not really one condition. And we do have to kind of think about the type of arthritis that is present, because that also influences our or affects our risk of developing uveitis. So for instance, the enthesitis-related arthritis, that's like the ankylosing spondylitis reactive arthritis type of arthritis, that's more associated with an acute anterior uveitis versus the extended oligoarticular arthritis, which is characterized by very few joints being involved. That is the category that has the highest risk of uveitis, and specifically the chronic anterior uveitis. And some of the other entities on here also have a risk of chronic anterior uveitis, but I just wanted to bring that to everyone's attention, that really the patients that we generally see with chronic anterior uveitis have fairly mild arthritis. Because of the nature of the chronic anterior uveitis in JIA, the uveitis is often picked up very, very late because it's very asymptomatic. I mean, essentially, somebody may have faint symptoms, but in general, patients do not know that they have eye inflammation. Their eyes are not red, they don't have conjunctival injection, and they don't know. So the risk factors for developing this form of chronic anterioritis are being female, having very few joints involved, so oligoarticular, ANA positive, and RNF negative. And the joint and eye inflammation are often not correlated. And so the joints may have been affected, and then a few years later, they may develop uveitis. And so this will be really important in terms of screening, which we'll talk about in the discussion. So unfortunately, because of the nature of this, the uveitis is picked up late often. And often it's when the eyes look abnormal because of band keratopathy or an irregular pupil due to synechiae. And many complications can happen due to the chronic nature of the inflammation, including cataract, glaucoma, macular edema, hypotony, and even ptysis, unfortunately. This is one of my patients who just the first time that she came to clinic, she actually had a remote history of JIA, but the joints had been self-limited, had been seen by a rheumatologist, never had screening for eye disease. And then finally came in when she and her family noticed that the eyes looked very abnormal. And you can see that the vision is very low in the left eye, and there's a synechiae, pupillary membrane, cataract. Even in the right eye, which looked normal to them, there was a synechiae, but the eyes look completely white here. And then this unfortunate left eye here that has had severe inflammation without detection. So I'd like to bring your attention when we focus on treatment to a recent paper, 2019, American College of Rheumatology published a guideline paper, and it talks about screening, monitoring, and treatment. And I think it's a good resource. It's really was an expert panel paper based on the level of evidence that we have, which sometimes is lacking, but I think it's a helpful paper. So in terms of management, topical steroids are still really important in the management of JIA uveitis. Because when you have active anterior chamber inflammation, and this is really an anterior chamber and anterior uveitis, topical steroids work well, and we use them to manage the acute inflammation or when we have a flare-up in a patient. But the goal is to limit their cumulative use because of the risk of cataract and glaucoma. And I'll talk about when we move on past that. But we do have other options that we often have to move on because this uveitis is often chronic and can go on for many years. We use many other immunosuppressive agents to spare the effect of steroids, things like methotrexate and even biologics. And cycloplegia is very important when there is active inflammation to try to prevent, the posterior synechia. So one of the questions that we always debate about in the uveitis world is how much topical steroid is acceptable on a chronic basis. And there's really not a definitive answer. I had done a survey, it's more than 10 years ago now, of American Uveitis Society. And they said that 2 times a day or less of prednisolone acetate or equivalent could be acceptable in some patients. Of course, some patients cannot tolerate this and have pressure problems, and it's not ideal. Jennifer Thorne from Johns Hopkins looked specifically at JIA uveitis and found that using 3 times a day or less of topical steroid was associated with a lower risk of cataract. This does not mean that all patients can be on 3 times a day for years, but it does mean that there may be some level of low dose topical steroid that could be acceptable in patients to control their inflammation. So in terms of the ACR paper that I just mentioned, their recommendation is that in children with JIA with chronic anterior uveitis, they recommend steroid drops, prednisolone acetate 1% over Durezol, difluprednate, because there's more pressure problems with difluprednate. And they recommend using it for short-term control. But the key is that and they say that if 1 to 2 drops a day are required on an ongoing basis, then that's not really acceptable, and that means that there's an indication to move on to systemic therapy. So keep that in mind, and then we'll talk about systemic therapy. But it's really generally not considered ideal or optimal to maintain patients on steroids long term. So moving on to all the medicines that I mentioned, how well do they work? Well, we're getting more and more information collectively as a field, but it's still fairly limited, I would say. So retrospective studies, and we have the SITE study, the Systemic Immunosuppressive Therapy for Eye Disease Study. They had almost 600 eyes with JIA uveitis, and they found that immunosuppressive therapy really reduced the risk of vision loss, particularly for the 20/50 level. So they followed patients, and if patients were treated with any immunosuppressive therapy, they had about 60% less chance of developing 20/50 or worse vision, which is really quite significant. And then there's great registry data out of Germany where they have a huge number of JIA patients, 3,500, and they followed them for development of uveitis. And what was significant here is that I think that really remarkably, the use of immunosuppressive drugs really reduced the risk of uveitis. So methotrexate, the hazard ratio is 0.63, so like a 40% reduction. TNF alpha inhibitors, also a very big reduction, but combination of TNF alpha inhibitors and methotrexate, the hazard ratio is 0.1, so basically a 90% reduction in risk of uveitis. And furthermore, if patients were treated early with methotrexate within the first year of arthritis diagnosis, they had an even lower uveitis risk. So this is promising. So methotrexate, though, may not be sufficient in everyone. It is our starting line treatment when we need to move on beyond steroids. It's widely available, it's inexpensive, it's pretty easy to manage. So it's a good drug, but sometimes patients still require steroids, which is not considered ideal, or they have a lot of breakthrough inflammation. And so so then we move on. And really the treatment of choice these days is adding a TNF, tumor necrosis factor alpha inhibitor. So adalimumab, which is known as Humira, is one that is now commonly used and is approved in many places for uveitis. And this is the Sycamore study from the UK, where patients who had persistent inflammation on methotrexate were randomized to continue methotrexate or given adalimumab. And you can see that the time to treatment failure was significantly less, slower for patients where adalimumab was added. And this trial was actually ended early because there was such a big difference in favor of adalimumab. Okay, so now we know adalimumab works. And the question is, one of the questions that I think we still have unanswered are when we treat is stopping therapy. And the ACR recommends at least 2 years of control and tapering off of steroids and still maintaining control before we try to remove immunosuppressive therapy. This is data from our clinic and from University of Illinois, combined data. It was about 50 55 patients or so, showing that when we try to stop TNF-alpha inhibitors, about half of the patients are flaring up within 3 months. And so our group, my research group, is doing a trial right now, and Ginny's part of this. It's NIH funded, looking at stopping adalimumab in patients who have JIA-associated uveitis. And in the interest of time, I'll just sort of kind of just give you a little bit of an overview, but we're really just looking at, comparing time to recurrence of uveitis and also arthritis in patients who are doing well on treatment, but looking at what happens when we try to stop versus continue. And I would say, even more importantly, we're looking for predictors of recurrence so that hopefully we can try to learn more as a field about, are there ways we can tell of who's going to successfully be able to get off of treatment? And a number of centers across the United States, United Kingdom, and Australia are helping with this effort. This is a patient of mine who, again, has very severe uveitis. This time it's aphakic in the right eye, came into me like that on adalimumab every 2 weeks, methotrexate maximal dose, and topical steroids. So sometimes we are not successful, even with all of these medications. She still had a lot of inflammation, 2+ cells, and high pressure on steroids, and also needed surgery eventually. She needed a lens implant. She, is aphakic in that eye, but clearly cannot get that with this kind of inflammation. So what are options in this sort of patient? You can go to adalimumab weekly. That has been now shown to be of benefit. You could go to a different TNF-alpha inhibitor like infliximab, and there are other biologics on the horizon that are being used: tocilizumab, abatacept, and rituximab for JIA uveitis. This is a study from Northwestern showing that if you go from every 2 weeks to once weekly adalimumab, about 14 out of the 25 patients were able to gain control. So, not everyone will succeed with that regimen, but it's good. And then I'm not going to get into these data, but just mention tocilizumab. There's not big trials, but there's data that's showing that, which is an IL-6 inhibitor, abatacept, which blocks co-stimulation of T cells, has some data. It's very small numbers, but I know it's being looked at for uveitis. And then rituximab, again, looks promising for JIA uveitis. So keep these in mind if we're having trouble controlling inflammation. The ACR says that we start with steroids, then we go to methotrexate. They recommend subcutaneous methotrexate because it has more bioavailability. We still cannot get off of steroids. To control inflammation, we add a TNF-alpha inhibitor. We do not use a etanercept because it doesn't work for uveitis, but usually adalimumab or infliximab. And we max out the dose of that before we move on. And we try often 1 or 2 TNF-alpha inhibitors before we move on to things like tocilizumab or those other medicines I mentioned. So in summary, for JIA uveitis treatment, we use topical steroids for initial control for flare-ups, but we don't want, in an ideal situation, to keep patients on steroids even 1 to 2 times a day for months. So we will move on, usually to methotrexate, and do a step-ladder approach in most cases, escalating therapy to biologics. But for severe cases, we are more and more using early TNF-alpha inhibitors, early biologics. And that's something that I think requires attention in terms of whether that's a benefit. We think there may be in severe cases patients who've already had vision loss. And then withdrawal of treatment really requires further research and very close monitoring because of the risk of flaring, especially in an asymptomatic condition. Thank you.
Well, that was a tour de force. Thank you so much. I'm going to open up the discussion. We've got listeners in Zambia, Romania, Greece, Taiwan, Israel, Honduras, Ecuador, Indonesia, Turkey. Somebody sitting in Ecuador. How easy are they going to be able to get a biologic? Somashila, are you going to be able to get a biologic in India?
Well, we have biosimilars in India, but there are 2 things.
What's the difference between a biosimilar and a biologic?
So Nisha, that's for you.
Okay, yeah. So, I think that essentially they're full clinical trials, the way that, that a novel medication would be. So I think the chemical or the structure of it has to be basically similar, and they have to show some safety data. To my knowledge. So it's basically another version. And what's happening is as these drugs are going off of patent, you're seeing many more biosimilars coming up. So for Humira, for instance, there's a number of biosimilars now that are thought to be identical. And, we don't have a lot of experience with it yet in the US. We have infliximab biosimilars now that I'm getting some experience with. For the most part, I think colleagues in India and the UK think that they're fairly identical in terms of efficacy. They're supposed to be, but I'm interested to hear if anyone in the panel has other thoughts about it.
Sana, any ideas, any comments? And then we'll come to Ginny.
Yeah, well, I was thinking that the same. So if they would just start methotrexate early on, we would not have that much uveitis. So that's kind of what we're dealing. In Finland is a high autoimmune disease country, and we have the world's highest JIA incidence and prevalence and uveitis incidence and prevalence in pediatric patients. And the more we just keep them on methotrexate and start methotrexate early, the less we see uveitis. So I think maybe prevention is key, something that we tend to forget about, yeah, in the high risk.
So that's an excellent point. And I think that data, that registry data, and you have a lot of data as well, really shows that. I think but one of the issues I have is that since many of the patients have oligoarticular arthritis, their arthritis may not be so bad. And they may have been, they lasted maybe, a few months, was managed with non-steroidal anti-inflammatory drugs or, a couple of steroid injections, and they never really recurred. So in that situation, it's hard sometimes to put everybody, all of those patients on immunosuppressive therapy. I mean, I love immunosuppressive therapy. I like to use it all the time, but I can understand from a family standpoint, right? They may say, well, the joints are not, they're fine. Do I really have to be on this drug for how many years? Years and years. So I don't know. We struggle with that. Of course, when they have uveitis. Yeah.
Sorry, Lisa, I just want to bring Ginny into this. Ginny, how do you deal with that? When you've got a parent who's got a child with active uveitis, as Nisha says, the joints aren't that bad. How do you convince them to get onto methotrexate? Because that's certainly what we do. I mean, we certainly push the methotrexate early. How do you convince them?
And that's a key point. You have to spend the time. You really have to educate and make sure that they're aware of the complications. And in some cases, when parents refuse, you have them get a second opinion. I basically say, I'm a parent too. If I have a question about something that's being suggested, why don't you see an expert, in this location locally or in another state? And some of my patients have actually taken me up on it, and they come back and they are ready to start immunosuppression. So, getting encouraging them to get a second opinion can be really helpful.
Ken, I'm going to take a couple of audience questions. There's one good question, I thought, because that's very relevant to the context from where I practice and people who are living in countries like mine. So probably this could be for anyone, maybe. So the question is, what is your threshold to start oral prednisone for acute uveitis? I'm guessing that in the scenario of severe uveitis that you mentioned. So should we routinely start oral steroids if you have papillitis? And if you start steroids, what dose and what goal for total oral steroid use?
So I should have mentioned this.
Okay, go ahead.
I should have. I forgot to mention this actually, and thanks for bringing it up. The ACR recommendations strongly discourage the use of oral steroids in JIA uveitis. I mean, I think if you had severe uveitis, you might be obligated to, but patients respond very well to high dose topical steroids, even with optic nerve hyperemia, papillitis. That all can resolve. Of course, if there's macular edema or other complications, there may be a role for adjunctive therapy. But I should have mentioned that. So it's a good question from the audience.
I was going to say, if you were talking about acute anterior uveitis or, something that's really fulminant with posterior segment inflammation or haze, then, that would be the circumstance that I would consider it. But I agree with Nisha that for JIA associated anterior chronic uveitis, topical steroids go a long way.
Yeah, and when it comes to the dosing, it's recommended to do 0.5 milligram to milligram per kilo, and then try to taper it down in like 2 to 4 weeks. Because if you go longer than that, you start getting the systemic side effects.
So we also would have to look at it in the context of posterior uveitis and pan uveitis. We do get pediatric VKH and sarcoid. So would there be any recommendation for oral prednisone in those cases?
We definitely use it in those patients. We start with 1 milligram per kilogram. We even give them IV methylprednisolone, which can be better tolerated. for multiple doses. But again, the goal there, especially in children, is early immunosuppressive therapy to try to spare the effects of, long-term oral prednisone. So I would be very much putting on early, for a posterior pan uveitis or for severe intermediate uveitis, we really move on to early immunosuppression.
Ken, if I may, I'd just like to ask Virginia one question on her talk. And she mentioned a very valid point that the investigations will be kind of tailor-made based on the phenotypic presentation that the patient has. So, Ginny, what would be your, well, not exactly a blanket kind of prescription, but what investigations would you get done for a child that walks into your clinic with uveitis?
So basically the labs that I would pretty much order for most patients. Well, I always order syphilis. I know that that's not usually something that you see in children, but you can, and you treat it with antibiotics. So, absolutely. And then, I always get TB testing, and if they go on biologics, they're going to need it anyway. So I always get that. And a CBC just to look for blood dyscrasias. And I do order an ESR and CRP, and I know a lot of people don't do that, but I'm kind of asking the question, is this the whole body or is this the eye? And so that kind of puts me in the right direction. I order a metabolic panel that includes liver and renal function and electrolytes. I'm concerned about the creatinine and a urinalysis. And those are kind of and then A and A I usually order as well. And then everything else is kind of phenotypically driven or by history.
Do you pay a lot of attention to serum ACE levels? And is that something that you do for the granulomatous cases?
I do order the ACE and lysozyme. It's not super useful in kids, unfortunately. If I have a high suspicion, I will usually get an ultrasound of the abdomen, because a lot of times there'll be other organs that are involved. Chest X-ray, potentially, but that's not really.
Yeah. So for some of the audience who are not as expert as you guys are, you're talking about sarcoid now, right? You're talking about the diagnosis of sarcoid.
Yeah.
I mean, how much sarcoid do you see in the Nordic countries, Sana? Is it common?
Not in children. We do have a lot of sarcoid, but not uveitis, like not sarcoid-related eye diseases. So I just did a screening study, and I had 2 over 100 sarcoid patients, 2 uveitis. So it's not
across the panel. How common is sarcoid in children?
I don't think it's that common. That at least as far as a list of entities, right? We think JIA. We have TINU, tubular interstitial nephritis, uveitis. We have pars planitis. We have some infectious causes. Sarcoid is on the list. It's just, I think it's much less common.
So Michelle,
I agree it's much less common, but it's not totally out. So when we have patients with granulomatous uveitis and we've done a workup and we don't see TB anywhere, we've done everything diligently. And then there's the question I was asking Ginny earlier was because of the kind of keratic precipitates, where you see the more pigmented ones and a little bit more dirty looking ones, which we attribute to tubercular etiology, and a little bit more defined and whitish ones, which we attribute to possibly sarcoid. And then, of course, we can do a serum ACE level, but we don't attribute that much significance to it. The main reason I asked this was because they can present with a Blau syndrome, and they can also have a hemorrhagic kind of involvement. And initially they might be anti-uveitis, but then pretty soon it comes out to be a pan-uveitis. And they are the ones that really need a lot of therapy. So they may be rare, but they're more diseased in that way.
Okay, so
I agree. Thanks for bringing that up.
For the sake of time, we're going to move on because we are running late, but that's fine. The discussion's great. So if I could invite Sana to share. While she's doing that, Ginny, I use a lot of wide field imaging, a lot. And, I've realized that on my panel, I can't see Mary Ellen. Mary Ellen, I apologize. We haven't pulled you in yet. So when we start the discussion next, you're going to be the first to give your views. Please don't be quiet. Okay, Sana, all yours.
Thank you. Thank you for the invitation. Greetings from Finland. We're very frozen here currently and dark. So my topic is complications in juvenile idiopathic arthritis-related uveitis. This is a common disease here in Finland. Let's see if I can change. Here we go. Ocular complications are really common in JI uveitis. We see at least 2/3 of the patient develop at least one complication. Complications impair vision directly. They can immediately impair the patient's vision, and they also associate with long-term vision loss. They always require some additional treatment, that is often surgical treatment. And I'd like to remind you that even if the complication is really well managed, the patient stays in a continued high risk for further ocular complications and further surgeries and for further vision loss in the future. So my question is how to prevent ocular complications in this disease. High intraocular pressure and related glaucoma are really common in JI-related uveitis. IOP is managed with eye drops and surgery is required quite commonly. Up to 82% of these patients require surgery. IOP rise is seen quite early in JI uveitis, often during the first 2 to 3 years of treatment, and it associates with glucocorticoid use. Surgery, when it's done, the success is quite guarded in JI uveitis. At best, we've been able to provide a 90% success rate with a multi-node drainage device implantation and IOP lowering medication up to 4 years. With the trabeculectomy, we were able to get a 73% success rate among a subgroup of patients who were on TNF inhibition at the time of the surgery. Postoperative complications are really common in JI uveitis and glaucoma surgery. At least half the patients develop something. Most of them require cataract surgery after the glaucoma operation if their cataract was not operated on before the glaucoma surgery. So the risk of severe vision loss is almost 4 times as high when a patient develops high IOP in JI uveitis than without high IOP. So we want to prevent this problem from happening. And what we can do is that we can control the uveitis. The target to hit for this problem is at least SUN1+, but maybe 0.5+ would be better. We want to avoid topical and intravitreal and systemic glucocorticoid treatment as our baseline treatment. And instead, we should focus in antirheumatics. And at least in my hands, the best anti-glaucomatose medication for these patients is a biologic treatment. So then to macular edema. Macular edema is the most common cause of vision loss in uveitis in general. It can be seen in up to 48% of JI uveitis patients. It associates with direct vision loss. But lately, at least here in Nordic countries, macular edema has become a rarer problem. And we think it's due to biologic treatment. Both adalimumab and tocilizumab seem really effective in treating macular edema in JI uveitis. And infliximab seems to work similarly as adalimumab, although there are no studies on it. So what to do to prevent macular edema from happening seems to be the solution seems to be biologic treatment. Glucocorticoids can be used in short term for macular edema treatment as a short-term bridging treatment, but they're not safe in the long term for children or any JI uveitis patient. I also advise against intravitreal treatment if you can find some other form of treatment, because complications are really common after treating this disease with intravitreal glucocorticoids. We see IOP rise and cataracts requiring surgery. Also a little problematic with the different options. Triamcinolone is not studied in JI uveitis, but it's very short acting for this problem as it's a chronic issue. Dexamethasone implantations work sometimes, but often not. And repeated treatment is required in most of the eyes with dexamethasone implantation. We studied the Retisert implant, and it was really brilliant for treating the macular edema, but our complication rate was 100%. So I would advise against glucocorticoids as a long-term solution for macular edema, but as a short-term solution for bridging before you can start biologics, it's a great choice. So then lastly, cataract. Cataract is the most common complication in uveitis. The surgery is performed already at 3 to 4.5 years after the diagnosis. These patients are young at surgery, median age 11. Surgical success in cataract surgery of uveitis patients is guarded, but we've been able to improve it some. We're able to achieve 20/40 vision in 65 to 85% of these patients up to 5 and 10 years. But postoperative complications are common. Complications are really common in these eyes undergoing cataract surgery already prior to the surgery, because complications tend to pile up in eyes. We see really high rates of secondary glaucoma and macular edema after surgery. But preventing can happen. So if you just control the inflammation as well as you can, try to avoid posterior synechia, like Nisha said, with dilating drops, then you should avoid glucocorticoid treatment as your baseline treatment. And you can focus in antirheumatics instead to prevent and delay cataract formation. So how to prevent ocular complications? You screen, so you can diagnose early and you can diagnose before ocular complications do occur. Then you should control the inflammation, limited to 5 cells and fewer, at least to that limit. Then you should start avoiding glucocorticoid treatment as your daily baseline treatment. And then you will start seeing reduced rates of high IOP and cataract and related surgeries. And then what will happen is that, like me, you used to study uveitis related complications, and you need to stop studying those because you don't have that many complications anymore. And instead, you start focusing in antirheumatic treatment. And as was said, antirheumatic treatment, especially methotrexate and anti-TNF inhibitors, they prevent and delay uveitis in JIA. But they also prevent and delay complications, and they treat complications, and they improve these patients' visual prognosis. Thank you for your attention.
Thank you so much. That was wonderful. Thank you. So we have so many questions coming in. If everybody can switch their videos on, I'm going to throw this first question. Somashila, you can throw some other ones out as well, but I'm going to start off with Mary Ellen. Mary Ellen, the question is how often would you follow a patient after stopping treatment of methotrexate? What would be how often would you follow them? You're muted, Mary Ellen.
I would follow every 3 months for GIA, for instance. I don't know what the other colleague panelists think.
Go ahead. What does everybody else think?
So I generally, when I stop therapy, will follow them closer. So if they're stable on therapy and I'm not changing, then every 3 months. But if I make a change, then usually really 4 to 6 weeks. So a lot sooner for me, just because I like to catch. I know the methotrexate doesn't completely wash out at that time, but I think these patients are at high risk for flare-ups. So I'd rather catch it early and try to manage it before it gets, to a higher level. So I guess it's just, I have a concern about their risk.
I agree. I do 4 to 6 week checkups after ending or reducing any treatment in these patients.
I would mention as well.
Sorry, go ahead. Go ahead,
something we haven't mentioned as well is just that when we start a methotrexate treatment, it takes a while, at least 1 or 2 months, to be efficient. And it's not the same when we use a biologic like anti-TNF that works really faster. So that's something to consider when we choose a steroid sparing agent.
So, so Mashila, I've got so many questions coming through. Do you have any that you want to throw out to?
Just a quick question, because Sana took the topic on uveitis-related complications. Sana, so what do you? So of course we're going to always have the occasional cataract and glaucoma, whatever therapy we use. So do you recommend any stepping up of therapy? There's a common question asked by most specialists. stepping up therapy before you undertake surgery for these patients?
Well, at least my study shows that if we keep the uveitis quiet for at least a year before the surgical results are a lot better after that. So we're able to maintain a really good vision afterwards. And the ones who have more than 5 cells, 3 to 12 months prior to the surgery, are also the ones who then have relapses after the surgery. So I try my best in upping my immunosuppression game prior to the surgery. So I would have the eye quiet at least for that 3 months, but I try to extend it so I could have 12 months of quiet anterior chambers before surgery.
So if it's quiet, you don't really step up, increase the dosage or anything like that. Yeah.
And so far, 0 macular edemas after cataract surgeries that I've had, my patients had children with, but they're on high anti-rheumatic therapies often. So I think biologics helped me a lot.
Great.
So I'm going to put this question, we'll go right across the panel. The question is any role of subtenon depot of steroids in cases with posterior involvement of JIA? So what does the panel think about that?
Jenny, do you want to take it? I comment first.
I think it's something to consider, but ocular hypertension is really a major issue, and you can't quickly withdraw the injection unless you do it more anterior. And so, it's not usually one of my first line approaches.
What about? Agree. Go ahead, Nisha.
No, I fully agree. I think, you'd have to take some of these young children into the operating room. So that's an issue as well. So we try to avoid that. And then the pressure issues. So I would use it kind of as a last resort, if you really aren't succeeding with topicals, high dose topicals, even short courses of oral steroid if we really needed it, because you can control that and you don't run into the pressure problems as much. But of course, if you have refractory macular edema, you do have to treat it. So you may have to escalate to a local therapy there.
So can I ask a question of the whole panel? Have you ever had a child who's been on topical steroids and not had a steroid response, who then you gave a posterior subtenons to and got a steroid response? Because I haven't. Has that ever happened to you? You've given topical steroids, no steroid response. You give a posterior subtenons and they get a steroid response. Has that happened?
So, Ken, I'd like to say that can happen. Most of us, we tend not to use intravitreal at least, but posterior subtenon also. Even if the child has not had a steroid response, if you're treating, we have a lot of children that we do for other indications like cystoid macular edema and so on. And they've been on topical and even oral steroids in some instances, and then we resort to posterior subtenon. They can have increased intraocular pressure.
How common is that?
It is rare, of course. I agree that it's rare.
Right. Because, sorry, go ahead.
Sorry, it depends as well how the subtenon injection is done. If it's underneath the conch and it's close to the limbus, the risk of having a high pressure is higher than it's released down inferior fornix, for instance.
Because I'm very conscious of the fact that there are people listening to us around the world who may not have access to some of the drugs we're talking about. And, for them to think that they should know that if they're using topical steroids and the pressure didn't go up, that a posterior subtenons, and I give it supratemporally, I don't give it in the inferior fornix, as we were talking the other day, Marilyn. It's a great way of delivering drug to the posterior segment. And it's something that Jack Kansky taught me 25, 30 years ago. We used to do it all the time. So, Ginny, what's your experience? How many children have had topical steroid, then had a posterior subtenon and the pressure went up?
I would say I agree. It is rare that a child would not, especially Durezol. Durezol is if their IOP doesn't go up with Durezol, much less likely for subtenons. You just have to be ready to, if they need to intervene if the pressure does go up.
So we have tons of other questions. We still have some talk, so I'm trying to balance this. How about this? It says, and I think, Sana, you answered this. What is your advice about the intraocular steroid implant? I think Nobody has any financial interest in Ozurdex, but that's the one that was named in the question.
Yeah, understand that's an appealing choice when we're treating, because we see it function so well and we see it work really well in adults. But in children, sadly, it's not that effective because the disease that we're treating is chronic in nature. And the macular edema, when we see the macular edema, it also is a chronic complication. It's not a complication like RVO where you could treat it once and it might not come back. It is a chronic relapsing complication. So then to give this patch of 6 months of a dexamethasone implantation, it's not smart. Like, you should come up with a better solution for a longer term solution. It can be like a short-term solution for you, but you also have to come up with a long-term solution.
Anybody in the panel disagree with that?
I think it's useful though as adjunctive therapy. I mean, I would definitely, it's a warning sign when you have that you need to do something with the systemic therapy, right? To try to get the uveitis under better control chronically. But for things like, especially macular edema, I mean, if you're not getting success with the, lesser strong therapies, at some point you've got to treat, right? Because you'll lose vision from it. So you may have to take the hit of pressure or whatever it is and deal with it and put the steroid in the eye in order to save the vision. So I think we find it, we try to obviously avoid this, but it is really helpful for macular edema. But if you use adjunctive steroid injections, being on immunosuppressive therapy will help to prevent recurrences. So it doesn't get you away from that. You still have to be on the systemic immunosuppressive therapy.
So my take is the same, similar to exactly what Nisha and Sanna also have been saying, that it cannot be the only therapy. It's not standalone. It can be adjunctive. But I think the go-to therapy has to be a systemic immunosuppression, immunomodulators, in whichever way, whether it's the biologics or whether it's methotrexate. And this can be adjunctive to tide over crises like very severe macular edema and so on. But it could well be a posterior subtenon. It could be that, or it could be Ozurdex.
Mm-hmm. So I'm going to ask Ginny one more question, and then we're going to invite Mary-Hélène to share. So Mary-Hélène, if you can start to share your talk. Ginny, the question is if you are suspecting sarcoidosis and your serology is not helpful and they have no skin and no lung involvement, how do you make the diagnosis? Or do you do a biopsy? What do you do?
Well, if you can biopsy anything, that's definitely the approach to go. But we do a abdominal ultrasound because a lot of times there'll be liver granulomas or renal granulomas because disease tends to be extrapulmonary. So that would be our next step there.
Okay, we'll throw that question out of the whole panel. So Mary-Hélène, thank you so much for giving this talk.
Thank you very much for the invitation. I'm very honored to be here. So I will just start to remind everyone that panuveitis and posterior uveitis are less frequent than anterior uveitis in children, like in adults. And where are posterior uveitis and panuveitis? They are in the back of the eye, involving retina and choroid. Just to remind also what are the diagnoses to consider for posterior uveitis among all the causes of uveitis in children. So infectious, not to forget about the toxoplasmosis in children, the retinitis necrosis related to zoster, herpes, and CMV in immunocompromised children. Lyme, Bartonella cat scratch disease frequent in children, Toxocara TB, Duzen, that's a single nematode, a worm in the retina. So sarcoidosis, Blow syndrome, Dr. Murty mentioned Blow, important to remember, VKH, lupus, Behçet disease, white dot syndrome, and masquerade. So we always need to keep in mind that leukemia is one of the major causes of malignancy in children, but retinoblastoma, trauma, intraocular foreign body sometimes can be misdiagnosed, Coats disease, this genetic disease, and retinitis pigmentosa. So first, toxoplasmosis, it gives a retinochoroiditis, and the arrow shows you here an active lesion, And there are also in this picture vitreous opacities and macular star. This patient was a 12-year-old girl, and the diagnosis was done by PCR toxoplasmosis in the ACUS. Fluorescein angiography can be useful, especially with a primary infection and an active lesion like that. So the FA shows early masking and late fluorescein angiography just around the lesion. This other child was a teenager. She had this active lesion, fluffy lesion, adjacent to a chorioretinal scar. And here is just to show you how typical the scar of toxo is, with atrophy and hyperpigmented borders. So now let's move on to the white dot syndrome, and the groups that can affect children are acute posterior multifocal placoid pigment epitheliopathy, or MP, multiple evanescent white dot syndrome, or MUDS, and multifocal choroiditis with panuveitis and punctuate inner choroiditis, or PIC. They are from the same group, these two last ones. So this teenager had small white deep lesions at the posterior pole, but spreading to the mid-periphery in the right eye. And on autofluorescence, you see that the lesions appears hyper-autofluorescent. And on fluorescein angiography, you have hyperfluorescent lesions from early to late phase. If you have access to ICG, you see that in MUDS, those hypoautofluorescent lesions are seen only in the late frames. That's typical for MUDS. It can help you with the diagnosis. And on OCT, we see a disruption of the photoreceptor, more particularly in the ellipsoid zone and interdigitation zone. MUDS is an epitheliopathy with RP involvement, and if you have access to OCT angiography, the choriocapillary is normal in MUDS. Another teenager, he was from Paraguay of origin, and he had headache with a loss of vision. It was bilateral lesions. They look similar in both eyes. And you see that the lesions are bigger than in MUDS. They are deep also in the posterior pole and spreading toward the periphery. Hyper-autofluorescent. It was MP, acute posterior multifocal placoid pigment epitheliopathy, and I will show you more pictures of them. So on OCT, there was subretinal fluid on the fovea and hyperreflectivity in the outer nuclear layer. On fluorescein angiography, this patient with MP had early hypofluorescence of those lesions, and they were hyperfluorescent on the late phase. And just to highlight the fact that those pictures were taken with oral fluorescein. And Dr. Nishal always mentioned in our meeting how good quality are the picture of fluorescein angiography with oral fluorescein. MP is a primarily choroidal inflammatory disorder leading to outer retina involvement. And if you have access to OCT angiography, you see that the choriocapillary shows flavoids in MP. MP, most of the time, heals with relatively good outcomes and spontaneously. In a course of 2 to 4 weeks, we use oral steroids, a short course when there is a foveal involvement. But just to highlight that there is sometimes, rarely, but it can happen, central nervous system vasculitis with a risk of venous sinus thrombosis, MP. So the last entity I will mention here is multifocal choroiditis and PIC. Female predominance can affect children and young adults, with sometimes enlarged blind spot, and you see the lesions, the white lesions deep in the choroid. And for angiography, they are hypoautofluorescent with a halo hyperautofluorescent. And on OCT, those lesions are typical, and OCT helps to make the diagnosis. So here in A, you see the RP elevation with sub-RP hyporeflective signal. In B, disruption of outer retinal layers and RP atrophy with window defect, and you see the lights of the scan going through the inner choroid, it's hyperreflective. On C, sub-RP deposit with hyperreflective signal, and E, focal choroidal thinning localized underneath atrophic peak lesions. And in D, you see sometimes hyperreflective dots in the inner choroid. So in pediatric and posterior uveitis, numerous infectious and non-infectious etiology, it's a vast topic, and it's a team approach with pediatrician rheumatologists for a proper diagnosis and proper treatment. Thank you.
Thank you so much. Well, it's gone a bit crazy, really. There are so many questions. I don't know where to start. So, Samashila, why don't you start picking a question? And what I'm going to do is I'm going to share the Menti question results while you start asking some questions.
So that was an excellent talk, Marianne, and you covered really a lot of ground in that short span, and it made it very interesting too. I just wanted Ken first to clarify one point from the previous discussion, which was kind of incomplete, and just want to very quickly revisit the subject of posterior subtenon and adjunctive therapy. So definitely for countries which are not resource rich and we cannot afford biologicals and so on, for many of our patients, yes, posterior subtenon and adjunctive therapy is very useful for controlling certain manifestations like cystoid macular edema, post-operatively, post-cataract surgery, and so on in pediatric patients, but cannot be the primary therapy. So that was the point everybody was making, I think, and the primary therapy has to be immunomodulators, and for anti-uveitis, more on topical steroids rather than posterior subtenon. So, but yes, definitely there's a very big role as adjunctive therapy. I just wanted to clarify because there were a few questions, and as well I got a few more on my own. Saying that why are you disregarding posterior subtenon as a use?
Yeah, no, we're not disregarding posterior subtenon. We're not.
Yeah.
So we're going to come to the panel. I just want to run through this to give everybody an idea of who's listening. So, how many pediatric uveitis patients do you see per month? So the majority are seeing 1 to 2. So there's a relatively few people who are seeing as many numbers as the experts on our panel are. Next, I'm going the wrong way. What have I done? Here we go. Oh, yeah, here we go. Do you treat severe or recurrent uveitis on your own? Yes, 74%, no, 26%. So I guess that's a good question for the panel. I have never treated uveitis where I've gone to systemic involvement with methotrexate or biologics on my own. I always involve a rheumatologist. I guess the people on the panel, you probably are, right? Because you're such experts.
I do treat them on my own, like I do. It's so common here. I do call rheumatologists whenever I need to, but they prefer me starting they call it my own medications for the patients. So that's what I do. But they're really helpful, and especially the pediatric nurses, then they follow up my patients' lab results, so I don't have to do any of that. And when the phone calls come in with the adverse effects, then the rheumatologist that helps me out. But I do have to start my own medications.
What about the others? Just a very short answer because we've got so much to get through.
I work with a rheumatologist or pediatric rheumatologist group, so they always help.
Me too. We have a great group.
I manage.
Yeah,
you manage?
I think Ginny. Sorry?
Ginny?
Yes, I said I work with
that was Ginny.
I work with a pediatric rheumatologist or several of them, although it's important to advocate for your patients and make sure that their doses are adjusted to treat uveitis as opposed to other rheumatic disorders.
Yeah.
We have to work often with infectious disease as well. As soon as the posterior segment is involved. Neuroretinitis is frequent in children, and multifocal choroiditis, and there are so much Bartonella, Lyme, TB causes.
Yeah, you know, in Pennsylvania, I've never seen, when I moved here, I couldn't believe, I thought everything that walked in had Lyme disease. It was unbelievable. Anyway, so we asked the question, if you don't treat on your own, who do you treat with? Rheumatologist, pediatrician, I don't know what other is. We'll have to try and figure that one out. What is your second line of treatment in JIA uveitis if your patient doesn't tolerate methotrexate? Nisha, do you want to comment on these responses?
Sure. Yeah, I mean, I think with methotrexate, first of all, you can try to increase tolerability by going to subcutaneous because you can have less GI side effects. You can also increase folic acid. We often in our clinic will go up to even 5 milligrams a day, or folinic acid leucovorin once a week. That can really improve tolerability. But it truly, you know, if that's not working, you have the option of either, I personally, because, you know, you could use another anti-metabolite like mycophenolate if that's what you have available to you. But personally, we would generally just go to a TNF alpha inhibitor at that point if it's available to us. So adalimumab.
Ginny, Sana, please. What's your comment on? I mean, I was interested about the systemic glucocorticoids. I don't know. Maybe it's just because they're available, but that wouldn't be something that I would necessarily think of.
Yeah, if it's
as a long-term.
Sorry, yeah, I think this is. I tried to ask for less a long-term solution instead of methotrexate. This is my question. So I do go for azathioprine and mycophenolate if it's a low-level inflammation, and if it's like not a very complicated disease that the child has had, and if their joints are doing well. So I try to do with another DMARD. But if it's a higher level inflammation, or if the arthritis is bad, then of course we go for anti-TNFs. But I do avoid systemic glucocorticoids.
Yeah, I use systemic glucocorticoids more for bridging therapy until, waiting for methotrexate to work. But our probably the next line would be anti-TNF alpha, infliximab if they're not compliant, because I know they have to show up for the infusion. But I would say adalimumab is probably the first anti-TNF alpha choice.
So here's a question. What medication do you choose when treating chronic macular edema in JIA uveitis? Who wants to, Mary Ellen, any comments on the answers?
Just to highlight as well that tocilizumab works well for macular edema, for uveitis with macular edema. But otherwise, the rheumatologist team I work with, usually they use adalimumab as well.
So that's pretty good.
As a first, they choose it as the first, actually, the first medication.
Any comments, Nisha?
Yeah, I mean, I think that adalimumab works pretty well for it, but I will say that sometimes, even with biologics, you still have persistent or refractory macular edema that will require adjunctive corticosteroid. That's the one instance where sometimes, you do need to have steroid injection, in the eye, but then hopefully long-term with immunosuppressive therapy, you will avoid many of those injections. That's the goal, but you may have to use it if it's not, responding.
Ken, for the previous question, I think that it would be for us, definitely we would use adjunctive therapy, local therapy, basically, either posterior sucking in or even intravitreal for these cases before we move on to, or if we can move on to adalimumab, or it would be bridging a glucocorticoid systemic in these cases if it's bilateral.
So, Sana, what do you think of this? In uveitic pediatric glaucoma, would you consider a goniotomy?
Well, if you have a surgeon who's really skilled with goniotomies, there's that one study where they had really good success with goniotomies. But I have a surgeon who's really skilled with multeno-implantations, and on my other side, there's a surgeon who's really skilled with trabeculectomy, so I choose those. So, and then between those two, I choose a multeno-implantation if it's a high level of inflammation inside the eye, and trabeculectomy with a quieter eye. But that's just my more like gut feeling, doesn't really come from a study.
So, I do a lot of the uveitic glaucoma, and you're right, goniotomy does work. I would say it works in about 70% of cases, not 100%. And often you'll buy 2, 3, even 4 years of control. There was a question earlier that if you put a drainage tube in and the pressure's still not controlled, what do you do? And I think that these are really tough cases sometimes. And you have to think about doing a goniotomy as well as, even if you put a tube in, if the pressure is not controlled and the optic nerve is being damaged, you need to think about that. But so let's go through some other questions. This is one for the whole panel, because I know everybody's got an opinion on this. In a JI-related uveitic cataract in a child, would you consider placing an IOL? 24% said never. 12% sometimes if the inflammation has been controlled for at least 6 months. Sometimes if it's been controlled for 1 year. Sometimes for at least 2 years. And nobody, thankfully, said almost always regardless of inflammation. So thoughts on that? Let's start with Ginny.
Yes, it's a setup for disaster if the inflammation is not controlled. So the longer you have the patient, the uveitis has been controlled, the more likely you are to be successful with the IOL. You also want to consider the status of the other eye and the other complications. An eye with hypotony would not be a great candidate for an IOL. So it's very case specific.
Nisha?
Yes, I think minimum 3 months, as Sana said, but we definitely prefer longer. We want minimum 3 months of good control. And good control does not mean on oral corticosteroids or tons of topical steroid. That's not really an acceptable long-term. So it really means, control on immunosuppression. We almost always are putting in an IOL in those cases, but if there's any concern, we'll leave them aphakic, right? And then put a secondary IOL. We don't even want to go into surgery unless it's controlled. But I think with biologics, honestly, this is changing, and most of our patients are ending up with IOLs now.
Marie-Hélène?
Yes, I completely agree to keep the eye off inflammation. And yes, there have been some study as well just before surgery using another DEX or any triescence. So that's something we can perhaps edema that's still there that's been there for a while, and we cannot get rid of it.
So,
Sheila,
just to add, Ken, that although it's not a direct answer to this, but it also depends on the age of the patient. And I think what we would like to follow is that younger child, maybe less than 11 or something like that, we might leave the child aphakic. Doesn't matter if the inflammation has been well controlled. And because we noted that the longer you have to keep using the immunosuppressants and the younger they are, the inflammation keeps recurring in our patients. And so a slightly older child, yes, we would control the inflammation and go ahead and put an IOL. But in the younger child, perhaps not.
So, I think probably we could have a whole session on cataracts in JIA because there's such a toing and froing. But so I'm going to move on. But I think there are so many important points there that have been made. Thank you. In most cases of acute AMPI, can you just watch because things will resolve spontaneously? So 86% said yes, and that, Marie-Hélène, that's true, right?
That's true, but usually it depends. There are studies as well showing not to give any oral steroid. It's a short course of oral steroids. Not to give any short course of oral steroids is foveal involvement, but usually we give oral steroids when there is a foveal involvement. And just to keep in mind, there is a new entity called relentless placoid chorioretinitis that look like MP. And in this condition, the disease progresses. There are more and more druids on TTNF alpha treatment for this rare entity, but not that rare actually.
Thank you. Ginny, what do you think of the answers to this? Which of the following are common findings in chronic anterior uveitis associated with juvenile idiopathic arthritis?
I think most of the respondents, actually everybody got it right. It's just that the 93% has the subtype oligoarticular JIA.
Yeah, so we've got a very, very well-read audience, clearly.
Yeah.
Okay, which of these conditions mainly affects children and young adults? I think this was yours, Marie-Hélène. Did they get it right?
Yes, and there was a mystery in there. The neuroretinitis is related to a worm, a nematode, and it affects more often children in different, not everywhere in the world.
Before we go on to the questions, normally when we ask this question, it's discussion, but I want you to notice it says great speakers. So that clearly is absolutely true. So let's open it up to the great speakers. I'm going to stop sharing. And there's a question here, Nisha, for you. It says, Does any of the panelists have experience with NRF2 activators as inflammation control adjuvants in rheumatoid arthritis?
I do not. I do not. I welcome anyone else commenting on that. No.
Okay. So there are so many questions. Somashila and I are trying to get through them. If we don't get through to them, don't worry. The panel will answer them. We'll create a PDF and send it out so you can get it from the website. Somashila, any questions?
As you said, there's so many questions. Many of them were related to the mainly to the therapy. And,
yeah. Okay, so here's one I've got. Have you come across VKH in the pediatric population? I have. So I guess you all have. How many? Go ahead, Lisa.
I mean, we should hear from Somashila as well. I know that they see a lot. We see a lot. We see a lot in the Cisco area because of our population. We have a lot of large Hispanic and Asian population. And especially in the Hispanic population, we get cases that are very severe already with full retinal detachments, tons of synechiae. They come very late presentation, unfortunately, because they live far away and just the lack of resources. So we see a lot. I see a few a month actually, which is a lot. And we're really aggressive with treatment to try to restore vision with tons of systemic steroids. I usually will give IV treatment with methylprednisolone and followed by high dose prednisone on a taper. And I almost always will start immunosuppression with methotrexate. And then often nowadays, if it's very severe, I'm actually doing methotrexate and a biologic.
Well, I'm glad I'm not a uveitis expert. I'm so glad Mary Ellen is working at the Children's Hospital. So let me ask that question. So, Sheila, what about you? Must see a lot, right?
Yes, we do as well. And unfortunately, it's usually missed as a diagnosis, although the patient may have gone to other places, and then it's similar. So the earlier the patient gets to us and we get them into treatment, the better is the outcome. And the later they get to us, then the outcome can be sometimes very, very bad. And it's very similar to Nisha, that's the regimen that we follow as well. Pulse corticosteroid therapy and a full dose of oral glucocorticoids.
For VKH, duration of steroid agent is at least 9 months to avoid a recurrence because they relapse a lot.
Yeah, we probably give it longer.
I've got a couple of questions for you. What protocol do you follow for screening for uveitis in JIA patients? Every 3 months or every 6 months? Can you give us a quick gestalt of what you do?
Who is this directed to?
Ginny.
Ginny.
Yes.
I basically, so we're talking about screening, or are we talking about patients that already have active?
Screening.
Okay, so for JIA, I usually follow the guidelines, the AAP guidelines. But if they're ANA positive, those are your highest risk. So those are the ones that the younger kids that are ANA positive, those are the ones you want to see more often. And then if they're ANA negative, it's more likely 6 months. But that's usually kind of the ANA positivity seems to be really key.
Where would you direct somebody if they wanted to have a look at the guidelines for screening? What? Go ahead, Nisha. Where would you direct them to?
I think I showed it in my slides that the American College of Rheumatology was published in Arthritis Research, Care and Research, 2019. Sheila Angeles Hahn is the first author from Ginny's institution. She's a pediatric rheumatologist. So that is the latest paper. It's 2019. It has screening guidelines based on type of uveitis, the age of presentation of the arthritis. So if it presents before 7 years of age and they're ANA positive, you follow every 3 months. If it presents later, you can extend it out. It has these guidelines are always evolving, but I would say that that's a good place to go to.
Sana, I got a question for you.
Those guidelines explain the treatment as well. The treatment as well.
Sorry, Mariella. So, Sana, let me ask you, do you
Ginny
use
had a
flare photometer in children?
Can you please ask me again?
Yeah. Do you use a laser flare photometer?
No, I don't have one. No, okay. I don't have one.
Fair enough. Yeah. Anybody else?
I used it when I was working in France. It was so useful. So I hope I will have it for Christmas next year, perhaps.
Okay, I'll work on that.
My
I was
business
going to
director,
say,
Very
like
easy
what-
to use.
and how important it is in following patients.
Yeah. Yeah, I think the French Professor Bodaki, they have it in their group and they've used it and they have brilliant research on it. So it'd be really nice to have, but don't have one.
I use it because Dr. Bodagi was my mentor, and I use it, and my life changed when I use it because it's very easy to use. It's like an OCT. Just press a button, and then you know instantly the level of flare, and you can compare the level of flare from one time to another one. So that's why it's very
no, we aren't using it in practice at all. But I think, Gary Holland at UCLA really likes it. And also, yes, our French colleagues, Dr. Bodagi, and in their trial looking at adalimumab, right? So they used it as an outcome and found that that was actually a pretty sensitive measure of following change in flare. So I think it's something that as a field, the issue is just getting, the machines are expensive. I think there's some people looking at these smaller machines or something, but I'm not a tech person, but I think there's some maybe movement into that, in order to make it more practical.
So we're coming to the end of our allotted time, but we're going to go over 5 minutes, only 5 minutes. So hang on, audience. We're not going to go much longer than that. So Mashila, I'm going to ask you this question first, and I want everybody just a yes or no answer. Otherwise, we're not going to get through all the questions. Okay, we're going to go through the whole panel. First question, so Mashila, to you: any role of topical NSAIDs in steroid respondents with JIA? Yes or no?
Darn it, Ken. I wanted to ask that question to the rest of the panel.
Okay, well, I'm starting with you.
So I'm not very sure if there's any really a role maybe in maintenance or adjunctive therapy, but for steroid responders, perhaps. I'm not very sure that it really helps.
What about the rest of the panel? Let's start with Nisha.
No, I'm going to say no.
Sana?
No.
Ginny?
No.
Mary Ellen?
the same. I don't really know. I don't use it.
Well, I think we've got consensus. That's pretty impressive. So, Mashila, do you want to ask the question about papillitis? Somebody's asked about the papillitis. Have you got that question?
Yeah, I think they kind of answered. It was answered because the question on papillitis was about the therapy that we use for steroids, oral
It's about
steroids.
IVFA. Should we routinely get intravenous fluorescein angiography? Now, at Children's at Pittsburgh, we do oral fluorescein, but should we get FA when you have a child with papillitis?
It's going to be technically challenging, I guess, but it depends. Nisha or Ellen?
We love oral FAs. I think if you're interested in transit, the choroidal perfusion with the choroidal disease, or obviously another vascular disease where you want to really see the timing of filling, then you have to do IV because you can't see that. You're going to miss the transit phase with oral. But honestly, for most of what we look for, optic nerve leakage, staining, late leakage, and vascular leakage, oral is great. And we are routinely, not in every patient, but whenever we have a concern, we love oral.
Mary Ellen?
Yes. With child with papillitis, I would definitely do an oral FA because you can see a retinal vasculitis that you're missing clinically, especially with the wide field fluorescein that we're having now.
But I do think we should be doing more of those in children. I think we're missing a lot of vascular leakage and a lot of other findings by, it's hard to do IV fluorescein. So I think we should be doing them, especially in intermediate uveitis, because they may have massive vascular leakage that's undetected.
I totally agree. Yeah, that's a great point. And even some of the anterior, what we think is anterior, there may be a posterior component. So even just getting a prelim or an initial study would be helpful.
So can I ask this question? I asked the panel before we came on live. When I worked with Jack Kansky many, many years ago, and more than I'd like to remember, we used to have a lot of patients who came from all over the United Kingdom, and they couldn't all turn up for their screening when they were supposed to. So Jack used to give them a bottle of tropicamide, and he used to say to the parents, twice a week, put a drop of tropicamide in both eyes, and if the pupil is irregular when it dilates, you need to come down urgently. because the iris will, the activity will have given posterior synechia. What tricks do you guys have for patients who may not be able to come as often as you'd like them for screening?
So even before the pandemic, and especially since the pandemic, I think the teleconsultation mode has been working very well, and use of smartphone. And Ken, your idea is just brilliant. Or maybe the idea that you talked about of you asking them to use home dilation once a week and having a teleconsultation that time. Trust me that almost everybody in India has a smartphone now and has internet connectivity. So that has been great, and it's been similar with many countries. And I think that would work very well because it's much cheaper than obviously traveling here. It's an excellent idea, Ken.
Well, not mine, Jack can. Anyone else?
I've started looking at my screening guideline with the more critical eye now with the pandemic. So I screen the patients who are on methotrexate, early start methotrexate, especially the ones with anti-TNFs and they don't have uveitis yet. I've started screening them less frequently. So I've already started doing that just because of the pandemic.
Yeah, no, I mean, these are excellent questions. I think we try to find somebody local also, for our patients who live far away. Even optometrists are often helpful. I mean, we still would like to see our patients back, periodically, but if they really can't make it, then working to find somebody that we trust locally, an ophthalmologist or an optometrist who could monitor them in between.
Perfect. Ginny, do you want to add anything?
Yeah, I agree with that. If you're able to coordinate with local care, and that's ideal. The tropicamide's an excellent idea, but I always worry once you have synechia, the cat's out of the box, and they're, that's so correlated with a poor prognosis. But that's certainly better than waiting until they have band keratopathy or a cataract.
Right.
So look, I can't tell you how much I've learned in this last hour and a half. It has been the most amazing experience, and you can see that it's the speakers that have made it possible. I have some housekeeping to do. When we finish the housekeeping, Somashila is going to ask every one of you for one last pearl. So you have to think about that. It has to be short and succinct. So the housekeeping is here. Everybody, remember what we said, in a time of disruption, create something. And these are the webinars that have been created with your help. I want you to notice that there are two coming up, February the 20th and the 21st. We don't normally do two at a weekend, but these ones are special. You can join us on the WSPOS Facebook page, the international listserv, that's David Granite's email address. We are a free member society. You do not have to pay to be a member of WSPOS, together apart all over the world. If you want a certificate of attendance for the webinar, please email program@wspos.org. 20th of February, we have this amazing group. We've got Conci Navarro, Aaron Miller, Savlin Kaur, Parth Shah, Federico Cremono, Chianti Darusman, and the moderators are Rahul Bola and Angela Fernandez. These are really interesting cases. We hope you'll join us. Now, on the 21st of February, we are doing the Hall of Fame, moderated by David Granite and Irene Gottlob. All the other speakers are speakers who gave the named strabismus lecture at one of the WCPOS congresses. You can email your questions and video clip questions, 30 seconds video at admin@wspos.org, or use your Dropbox link. Make sure you send your videos before 1700 GMT on Monday, the 15th of February, and then the moderators will pick which ones they think are the best, and we'll have this live discussion. This is going to be like one of the best talk shows you've ever heard in pediatric ophthalmology and strabismus. We tried to get somebody really good, but David Granite was the only person we could get to moderate. But thankfully, we got the brilliant Irene Gottlob. David, I know you're listening, and you know I love you. Okay, so you can go to YouTube. I have to thank NPOD. I have to thank Dara McCafferty, Akila Acharya, Emma Hester, free membership, and I'm going to stop sharing. Please join the YouTube channel because you'll get notification of when these are coming up. Somashila, take it away.
Right, Ken. So, Mary Ellen, can we have the clinical pearl from your talk or from your wisdom?
Can you, sorry, I missed the question
So can you give us your last take-home message?
Okay. Thank you. I would say retinal imaging is key in posterior uveitis to get the correct diagnosis and then to get the right treatment.
Excellent. Sana, how about you?
So prevention is key. So methotrexate for high-risk children to prevent uveitis and especially then to prevent complications, any methotrexate or anti-TNF.
Nisha, your words of wisdom.
I would say because treatment can be an ongoing process that takes years and years, the biggest thing I think is building a relationship with your patient and family so that you have trust, so that they trust you, because it's going to be an ongoing discussion, and that part is key.
Awesome. Ginny, last but not the least.
All right. So when evaluating a patient with uveitis, really be thorough in the evaluation and documentation. Get those records. Those are key, if I can give one pearl.
All right. Over to you, Ken.
So I want to say a big thank you. I forgot, and I apologize. On the 19th of February, there is this amazing day organized by John Ferris, Ramesh Kekaduya, and David Granite. It's going to be the Pediatric Ophthalmology Day. There's so much going. We'll be sending an advert out about this. So that will be on the Friday. So Friday, Saturday, Sunday, very busy if you can join us. I want to say, Somashila, thank you so much for co-moderating with me. I have never felt like I knew so little. Thank you so much for making me feel like that. God bless you. I just want to let you know, I just got the figures. I have never been to a uveitis lecture where we've had over 3,000 live viewers. Congratulations. Thank you very much indeed. Goodbye. God bless wherever you are in the world. We hope you've enjoyed it. Take care.
Thank you, Ken, and so much, Sheila.
Thank you very much,
Good to
Ken.
see you,
Thank
Jen, Asani, Marie.
Bye. Bye, everyone. Thank you.
Bye. Thank you.